You've spent a lifetime trusting your doctor's orders, but what if the very tests you're asked to take after 70 are actually slow poisoning your health? Imagine a routine blood draw that raises your inflammation instead of lowering it, a scan that adds more radiation than protection, a screening that sends you down a cascade of unnecessary treatments. In the next few minutes, I'll reveal the 5 routine checkups most women over 70 should stop and what you can do instead to stay vibrant and safe. Are you ready to protect your body from unnecessary harm? Stay with me because the first test on the list will shock you. Welcome to Senior Health, the channel where science meets everyday wisdom for the golden years. I'm Dr. Anna Martínez, a geriatrician with 20 years of experience caring for women just like you. A lot of medical guidelines were written decades ago when the average life expectancy was 20 years lower. Today, many of those blanket recommendations can trigger chronic inflammation, unnecessary radiation, or stress, induce glucose spikes in women over 70. Today, we'll list the 5 checkups, explain why they can be more harmful than helpful, and give you practical alternatives you can discuss with your physician. If you find this information valuable, give it a like now. It tells the algorithm that seniors need more of this content. Let's start with the first culprit that many of us still take for granted. 1. The full body CT scan, marketed as the ultimate early cancer detector. But why does a single snapshot of your skeleton become a radiation bomb for a 70-year-old? The biological impact is clear. CT uses ionizing radiation that can damage DNA and increase the risk of secondary cancers, a risk that grows with age because DNA repair mechanisms slow down. Most studies show that for asymptomatic seniors, the false positive rate exceeds 30%, leading to unnecessary biopsies, anxiety, and even surgery. Instead of a blanket scan, ask your doctor for targeted low-dose screenings, only where there's a genuine risk, such as a low-dose lung CT if you're a former smoker, or a mammogram if you have a family history of breast cancer. This focused approach cuts radiation exposure dramatically while still catching the most common threats. 2. The annual colonoscopy, a test that has saved lives for younger populations. Yet after 70, the balance shifts. Why? The colon's lining becomes more fragile with age, and the preparation process can cause severe dehydration and electrolyte imbalance, especially in women who are already prone to bone density loss. Moreover, the risk of perforation during the procedure rises sharply, and many polyps found in this age group are benign and unlikely to progress to cancer within a typical remaining lifespan. A better alternative is the stool DNA test, a non-invasive option you can do at home. It detects the same high-risk markers without the stress of sedation, bowel prep, or radiation. Talk to your physician about switching to this test if you've had a clear colonoscopy in the past 5 years and have no new symptoms. 3. The routine thyroid panel performed every 6 months. The thyroid does change with age, but frequent testing can create a false sense of urgency. Why does this happen? Small fluctuations in thyroid-stimulating hormone are common after 70 and often reflect normal aging rather than disease. Overdiagnosing can lead to unnecessary medication, which in turn can cause heart rhythm disturbances or bone loss. Instead, schedule a single baseline test after a thorough physical exam and only repeat it if you develop symptoms such as unexplained weight change, fatigue, or heart palpitations. This measured approach respects the body's natural rhythm and avoids the cascade of medication side effects. If this is blowing your mind, hit that subscribe button and let's keep exploring together. What do you think about the full body scan debate? Drop your thoughts in the comments. I really want to hear your perspective. 4. The yearly bone density scan, often recommended to monitor osteoporosis. While bone health is crucial, the frequency can be excessive for women who have been stable for several years. Why? Repeated scans expose you to small amounts of radiation and can lead to overtreatment with bisphosphonates, which have been linked to rare jawbone issues and atypical fractures. A smarter strategy is to extend the interval to every 2 or 3 years if your previous scans have shown no rapid loss combined with regular weight-bearing exercise, adequate calcium and vitamin D, and balanced training. Discuss this schedule with your doctor. They'll appreciate a plan that balances vigilance with safety, 5. The routine prostate-specific antigen test, often ordered for men but sometimes extended to women in experimental settings. In women, the test is not a standard screening and can lead to confusion and unnecessary follow-up. Even when used, the PSA can fluctuate due to benign conditions, causing anxiety and invasive procedures that carry their own risks. The best course is to focus on symptom-based evaluation rather than routine blood markers, especially after 70 when the likelihood of aggressive disease is low. If you have any urinary symptoms, bring them up directly with your clinician. They'll know the appropriate next steps without resorting to blanket testing. Now that we've covered the first two and hinted at the next three, let's pause and reflect. You've just learned how a full body CT scan, an annual colonoscopy, and a frequent thyroid panel can do more harm than good after 70. Remember, the goal isn't to avoid medical care, but to choose the right care. If you're finding this valuable, tap that like button. It helps more seniors discover these insights. In the next segment, we'll dive deeper into the bone density scan, the PSA test, and the final hidden culprit that many older women still endure without questioning. Stay tuned and keep questioning the status quo for your health. Where we left off, let us now turn our attention to the third test on the list, the bone density scan, often called a DEXA scan. This imaging study has become a routine part of many senior health checkups, and for good reason. It can reveal loss of mineral content before a fracture occurs. Yet the frequency with which it is repeated after the age of 70 can be counterproductive. Why does a scan that measures calcium in the skeleton sometimes become a source of hidden danger? The answer lies in the cumulative effect of low-dose radiation and the cascade of interventions that follow a marginal change in numbers. When a DEXA machine projects a narrow beam of X rays through the hip and lumbar spine, each exposure adds a tiny amount of ionizing energy to your cells. One scan by itself is considered safe, but when you repeat it every 12 months for several years, the small doses add up. In a body that is already experiencing slower cellular repair and a natural decline in antioxidant defenses, even this modest radiation load can contribute to DNA damage over time. The scientific literature points out that the risk, while low, is not zero, especially for those who have already been exposed to other imaging studies throughout their lives. Beyond the radiation issue, the interpretation of DEXA results can lead to overtreatment. A slight dip in bone mineral density may prompt a prescription for bisphosphonates, selective estrogen receptor modulators, or newer monoclonal antibodies. While these medications can be life-saving for individuals at high risk of fracture, they also carry rare but serious side effects such as atypical femur fractures, osteonecrosis of the jaw, and in some cases, severe musculoskeletal pain that forces patients to discontinue therapy. The decision to start a drug based on a single point change in a scan, especially when the trend has been stable for years, may expose a woman to more harm than benefit. So what is a smarter approach for women over 70 who have already been diagnosed with osteopenia or mild osteoporosis? First, consider extending the interval between scans to every 2 to 3 years. If your previous results have shown no rapid loss, this reduced frequency still provides enough data to detect a meaningful trend while limiting cumulative radiation exposure. Second, focus on modifiable lifestyle factors that have a proven impact on bone health. Weight-bearing activities such as brisk walking, dancing, or gentle resistance training stimulate bone remodeling and improve balance, reducing the risk of falls. Adequate intake of calcium from dietary sources, think leafy greens, fortified plant milks, and low-fat dairy, combined with vitamin D, which can be measured with a simple blood test, supports mineralization without the need for high-dose supplementation. Third, discuss with your physician the possibility of using fracture risk calculators such as the FRAX tool, which incorporates age, sex, previous fractures, glucocorticoid use, and other clinical factors to estimate the 10-year probability of a major osteoporotic fracture. This risk-based method can guide treatment decisions more precisely than bone density numbers alone. Now let us move on to the fourth item, the prostate-specific antigen test, a marker that most associate with men's health, but which occasionally appears in experimental protocols for women. You might wonder, why would a test designed to detect prostate tissue ever be offered to a female patient? In some research settings, clinicians have explored PSA as a nonspecific indicator of inflammation or as a surrogate for certain hormonal pathways. However, the test biology is not aligned with female anatomy, and its levels can fluctuate due to benign conditions such as urinary tract infections, kidney disease, or even hormonal fluctuations during menopause. When a woman receives an unexpected elevation, the result can trigger a cascade of additional imaging, biopsies, and specialist referrals that carry their own risks: radiation exposure, procedural complications, and importantly, anxiety. The core principle here is that screening should be grounded in evidence that the test predicts a disease that can be effectively treated in the target population. For women over 70, aggressive prostate-type cancers do not exist, and the likelihood of a PSA elevation indicating a clinically relevant malignancy is essentially nil. Therefore, the PSA test adds noise without benefit, and the downstream interventions can cause more harm than any theoretical gain. If you ever encounter a recommendation for a PSA test in your medical chart, ask your doctor to clarify the rationale. A simple question, what condition are we trying to detect with this marker, can reveal whether the test is truly indicated or simply a relic of an outdated protocol. In most cases, the answer will be that it is not needed and you can confidently decline the draw. Instead, focus on symptom-based evaluation. If you experience urinary urgency, frequency, or discomfort, bring those specific concerns to your clinician. They can assess for urinary tract infections, bladder dysfunction, or other age-related changes using appropriate evidence-based methods. Having examined the bone density scan and the PSA test, we arrive at the fifth and final hidden culprit that many older women still endure without questioning: the routine annual electrocardiogram, or EKG, performed even in the absence of cardiac symptoms. The EKG is a valuable tool for diagnosing acute arrhythmias, myocardial infarction, and certain conduction abnormalities. Yet when it is ordered as a blanket screening test for every senior woman each year, its utility diminishes sharply. Why does a simple tracing of heart electrical activity become a source of unnecessary worry? The answer lies in the high prevalence of benign age-related changes on the EKG trace. Minor variations such as slight prolongation of the PR interval, nonspecific ST segment depressions, or isolated premature beats are common in older adults and rarely predict adverse cardiac events. Nevertheless, when a clinician sees an abnormal notation, the reflex is often to order further testing. Stress echocardiography, coronary calcium scoring, or even invasive angiography. Each additional study brings its own exposure to radiation, contrast agents, and the psychological burden of a possible heart problem. Moreover, the cascade can lead to the prescription of antiarrhythmic drugs or anticoagulants, which carry risks of bleeding, electrolyte disturbances, and drug interactions, especially in a polypharmacy environment typical of the elderly. A more nuanced strategy is to reserve the EKG for women who present with specific symptoms such as chest discomfort, unexplained shortness of breath, palpitations, or syncope. In the absence of these red flags, a comprehensive cardiovascular risk assessment looking at blood pressure, lipid profile, smoking status, diabetes control, and physical activity provides a clearer picture of heart health than a silent trace. If your doctor insists on an annual EKG, ask whether the result will change management, and discuss the possibility of extending the interval to every 2 to 3 years or only performing it when clinically indicated. Let's pause for a moment and reflect on what we have uncovered together. We started by questioning the full body CT scan, which can deliver unnecessary radiation and spark false positive scares. We then examined the colonoscopy performed annually, a procedure that, while life-saving in certain age groups, may cause more harm than benefit when repeated beyond the age where polyp progression slows dramatically. Next, we explored the frequent thyroid panel, a blood blood tests that can lead to overdiagnosis of subclinical abnormalities and unnecessary medication. We continued with the bone density scan, highlighting the importance of spacing out imaging and focusing on lifestyle and risk calculators. We dissected the PSA test, revealing its lack of relevance for women and the cascade of anxiety it can provoke. Finally, we uncovered the hidden culprit of routine annual EKGs that generate needless downstream interventions. The overarching lesson here is that medical care is not a one-size-fits-all checklist. As we age, the balance between benefit and harm shifts, and what once was a prudent screening can become an avoidable source of stress, expense, and iatrogenic injury. The key is to engage in shared decision-making with your healthcare team, armed with knowledge about the evidence, the potential downsides, and your own values and preferences. If this journey through the maze of senior health screenings has resonated with you, I invite you to share your thoughts in the comments below. Have you experienced any of these tests, and did you feel they were truly necessary? Your stories help build a community of informed seniors who can support each other in navigating the healthcare system wisely. Before we close, remember that the best care is proactive yet measured. Keep a regular schedule of physical activity. Nourish your body with whole foods rich in antioxidants. Maintain strong social connections, and stay curious about the medical advice you receive. When a test is suggested, ask yourself 3 simple questions. Is there solid evidence that this test improves outcomes for someone my age? Could the result lead to a cascade of further procedures that might do more harm than good? And most importantly, does this align with my personal health goals and quality of life priorities? If you found value in this discussion, please give the video a thumbs up. Your click not only tells the platform that seniors are hungry for evidence-based guidance, it also helps more people discover this information. And if you haven't already, consider subscribing to the channel and ringing the notification bell so you won't miss future episodes where we demystify other common medical myths and empower you to make the best choices for your golden years. Thank you for staying with me through this deep dive into health checkups that may be doing more harm than good after 70. Until next time, stay vigilant, stay informed, and keep questioning the status quo for the sake of your health.